Assalamualaikum and salam sejahtera, ladies and gentlemen. Thank you very much, Dr. Edmund and Dr. Leong, for the informative and enlightening session. And it gives me a great pleasure to introduce our second presenter for today's webinar. Dr. Nadirah Azis is a clinical sports medicine specialist at the Department of Sport Medicine, UMMC. She will be sharing on the return to physical activity strategies after COVID-19 infection and the experience that by the sports medicine department. And without further ado, ladies and gentlemen, please welcome Dr. Nadirah.
All right, Assalamualaikum warahmatullah, and a very good morning to everyone. Hope everyone's still with me. After that, I have to follow that great presentation by Dr. I didn't know that the author of Mr. Arthur Conan Doyle wrote in The Lancet, wow, really sets a high bar for the rest of us. Well, as introduced by Prof. Sharif, my name is Dr. Nadirah Azis. I'm a clinical specialist with UMMC. And if Dr. Leong was looking back, we're looking back until the 1980s. We're only looking back until last year. This is actually an overview of the return to physical activity and post-COVID, the sports medicine experience. All right, let's begin as to a small case just to begin my CME. So initially we had this case coming to us last year in about June, a 36-year-old Malay gentleman, underlying obesity, referred from primary care for exercise prescription. So this is a typical patient, typical type of patient that gets referred to sports medicine. But upon further history, we discovered that he was recently recovered from category 2 COVID, about 3 months prior to referral. During acute COVID, he had fever, runny nose, cough, anosmia, fatigue. So category 2A, nothing significant. Acute symptoms resolved within 10 days, but the fatigue persisted until presentation in sports medicine clinic. Otherwise, he had no chest pain, no difficulty breathing, no palpitation, syncope, just basically very keen to restart exercise to improve his health. As you know, any illness, especially COVID, was a bit of a health scare for him. So he wanted to come in and see us in terms of how to restart exercise, especially because he had that persistent fatigue plaguing him post-COVID. So this was a new kind of patient for us in sports medicine. Though exercise prescription was common, it was how do we approach patient post-COVID, especially those with mild infection, meaning a category 2 COVID, coming with persistent symptoms, looking to start exercise. So of course, when we have this kind of cases, what we do is looking back at the available literature. So we look back, this also came back last year from the Ministry of Health in terms of management protocol. But if you look at the algorithms provided in the MOH care for post-COVID patients, it had flow mostly targeting category 4 and category 5 post-COVID-19 patient. As I said earlier, the patient that came to us was actually a post-COVID category 2, so fairly mild infection. So if you look, it's actually not captured in the algorithm by the Ministry of Health. So, so we looked at our own internal University Malaya post-COVID team MDT guideline that was available. And again here, because I think it was the load of patients that was already coming with moderate to severe infection, even our MDT here was not capturing that group of patients. So they were mainly focusing on those that needed more care, primarily those from category 3, 4, and 5, and they had teams supporting those. So there was really no local guidelines available as to how do we approach and how do we sort of clear these patients, especially after a mild post-COVID infection. So when there's no available guidelines, of course, this was the flow of what we had to do to where we are today. So after that patient came, we had a department level CME, more literature review. Then in December 2021, we actually presented to the national CME, meaning to all our sports medicine colleagues around Malaysia, came up with a guideline, a proposed guideline. And then in February 2022, we actually collaborated with the National Sports Institute and Cardiology Unit of UMMC. In May, just a few months ago, we had a bingkai penyelarasan for garis panduan COVID-19. And here we are today actually sharing what we have been doing over the past 18 months or so. So back to that patient. So how do we return him to physical activity and exercise? So like I said, there's no local guideline, so we had to go through the literature. So keep in mind that we did this last year. So we look back at 2020. I won't ask you to look at all. I just wanted to draw attention to 2 parts specifically, as how long they should rest after a sort of mild to moderate infection, and also how do we clear them, meaning what is the recommendation in terms of clearance, as in how do we say, all right, you're good and you can start exercising. So if you see different guidelines were published internationally at that time, of course, with no evidence, it's like a consensus statement. So like for this one from German Sports Medicine, even a category 2 infection, they required the whole works. You see FBC, CRP, transaminase, CK, creatinine, urine, exercise, ECG, stress test, echo, spirometry. So this was, I think, in the earlier stages of the COVID pandemic, people were being very, very much more cautious. So even category 2 required quite a lot of screening and assessment before allowing them to return to exercise. It was a trend that held almost throughout 2020, if you look at the literature. So you see here again, even ECG, history. So just looking briefly, right, 2020, the Dutch also came up with their own guideline. Here, they did not recommend extensive screening, but they said case-to-case basis. Then BJSM, British Journal of Sports Medicine, they were even more cautious at that time. In 2020, they recommended even mild infection go through the whole works, including echo, cardiac MRI, possibly Holter, and also a cardiopulmonary exercise testing. So how did this trend change as the pandemic moved forward? So you see towards late 2020 and early 2021, the trend started to change. So while the earlier papers were very cautious and a lot of investigations were required, as we moved into the later stage of the pandemic, people started to become more liberal. So while there was still some recommending full screening, others started to become more liberal or more relaxed in the recommendation, like this one earlier by Phelan with the American College of Cardiology said that asymptomatic and mildly symptomatic cardiovascular testing may not be necessary prior to return to play. So I'll just fast forward to give you, so this was one of the later paper in 2021. So looking at this paper, Kim et al. Published in from the American Medical Association. So here for asymptomatic category 1, cardiovascular testing was not necessary. Similar with mild infection here, category 2, but if you had individualized consideration was reasonable if protected cause of illness, meaning if you have any lingering symptoms, they do recommend further testing. So after reviewing all this literature, this is what we came up with in our sports medicine unit. Getting return to physical activity, meaning those looking to return to exercise, like that case that came earlier, meaning from primary care coming in. So we adopted some of the MOH recommendation. For example, if they come in, so what do we screen for first? Make sure they have no red flag. Red flag here meaning no chest pain, no difficulty breathing, no hypoxia, no syncope, no delirium or focal neurology, and no persistent fever or persistent GI symptoms. So if they do have any of the red flags, if they are clinically unstable, then of course, to send them down to ED, if not, to refer them out. So assuming they have no red flags, then proceed to the pre-participation evaluation. So here, I'd like to draw your attention to this part, category 1, 2, 3. So we decided, what did we decide to do? We decided to make sure they have a full investigation, including your basic blood investigation, but we did not make it mandatory for exercise testing. For example, stress test, we only required a resting ECG and basic blood investigation to clear the patients. So if patients had no further abnormalities, then we looked at their functional, whether they had no abnormalities, whether they were participating at a high level. So I will talk later why participating at a high level required further consideration. But if they weren't, they were just like that patient earlier that came. So they can actually, after clearing the basic investigation, they can go ahead to graduated return to physical activity or sports. So why did we add this? What is this PCFS? So if we did this algorithm for that patient that came just now, he was a category 2, he had completed rest, he was already 3 months. All basic investigations were normal, they had no abnormalities. However, he had persistent fatigue, remember? So because of the persistent fatigue, we did this PCFS, which is a post-COVID functional scale. So this one we adopted from the MOH guideline, seeing whether you can function with those symptoms. So anyone with 0, 1, 2 scoring, meaning a negligible or mild limitation to their functional activity, we allowed them to proceed to advanced investigation. If those with moderate to severe functional disability, to give you a range, PCFS 3 and 4 would be those who cannot dress themselves, cannot do ADL, cannot be independent. So those clearly cannot go to GRTP or graduated return to play. So like that patient, because he was actually functional, he was already back to work. It was just that he still complained of fatigue. So he said he was already back to work. He was already back to activities of daily living. All he wanted to do now was return to exercise. So we actually did advanced investigation. In his case, we did a cardiopulmonary exercise testing, which actually revealed just reduced fitness, meaning reduced anaerobic threshold and reduced VO2 max. Then we tailored his exercise prescription, and actually he was good to go, and symptoms improved with tailored exercise prescription for that patient. So that became sort of like the model of screening and flow that we were doing for patients returning to exercise among the general population. So then where did we go from there? Right, so I told you that was the first part was return to physical activity. So so we came up with the algorithm, we tested it with a few patients, we were fairly happy, the literature matched what we were doing. So we were doing that until about early this year, when I think because I told you there was no consensus, meaning there's no, each country internationally had resources, what are the local resources available for them, also the kind of specialty and what kind of specialty available for that country as well. So we had to sort of like individualize according to each country. So upon hearing that we had this program on board, we were actually approached by our colleagues in National Sports Institute. So they wanted to sort of consult and also come up with a similar sort of guideline, but now concerning primarily their patient population, which is the high level or national level athletes. So we sort of had to sit down with them to come, and we formed this group. It's not an official working group. It's sort of like a discussion between National Sports Institute, us, and of course, we couldn't do this without really the great help from our cardiology unit, of course, Prof Imran, and also then involved with us on a day-to-day consultation was Dr. Noor Ashikin. So they sat down with us and tried to sort of fine-tune the previous guideline for general population and how we were going to use that for our athletes. Then the next question you asked, right, that I told you, why the difference? Why should there be a difference in screening the general to exercise compared to athletes going for high-level competition or national-level athletes? So the literature showed, like Rajpal et al. In 2021, he studied 26 college athletes who were asymptomatic, basically Cat1 or Cat2 post-COVID, and he screened them, all of them, and in 4 out of 26, means 15%, had evidence of myocarditis on cardiac MRI. His findings were duplicated, so-called, in a bigger cohort, 789 professional athletes, and they screened as well with high sensitivity troponin, ECG, echocardiography. Then from there, they stratified those who went for cardiac MRI. And from those tested, they had a number of 3.8% coming up with myocarditis out of 3 out of 30. So then Daniels, again, these are all studies, I think, coming out of the US at that time. So they had an even larger cohort, 2,461 college athletes. And out of that, 64.9% went for comprehensive testing, including cardiac MRI. And out of that number, actually their pickup rate was 2.3%, demonstrating myocarditis by cardiac MR imaging. So in this summary, Udelson did a systemic review in 2021 and said that, so the evidence review puts the range of athletes coming with myocarditis at 1 to 3% post-COVID-19. So this was really, for us in the sports medicine field, this is really eye-opening because it's sort of telling us that even those with Cat1 or Cat2, which is actually among athletes, most of them are in this category, just Cat1 or Cat2 post-COVID, somehow they can still develop myocarditis as evidence on cardiac MRI. So that was sobering, to say the least, when we did this review. So we really decided that, yes, we do need a different way to sort of clear our athletes because of this data that came out. So this was the data summary, just in table form. So how did we do it differently for our athletes? So basically the flow is still the same. But when it comes to this level, we sat down with our cardiology and decided how are we going to screen our athletes. So it became this flow instead. So for our athletes, if they cleared, then if they are Cat1  2 or 3, meaning mild post-COVID mild infection, then they get screened for presence of cardiovascular symptoms. So what are presence of cardiovascular symptoms? Actually, according to the literature, Kim, is there anything like shortness of breath, chest pain, any chest tightness, any pressure at rest or exertion, any reduced effort tolerance or exercise intolerance, any dizziness, palpitation, syncope, all of those fall under cardiovascular symptoms. And if any of the athletes have that, they get flagged up to go for further testing in the form of ECG, as well as an echocardiography and also an exercise stress test. So we divided it into two portions as to what test we did. So from cardiology side, they decided after the basic investigation, they also wanted an echocardiography and exercise stress test. From our side, we proceeded with a spirometry and also a cardiopulmonary exercise test. So if they cleared all of this, then discussion is made whether they needed to proceed or not. But if there's any of this that sort of were abnormal or suspicious, then patients did get proceeded to getting a cardiac MRI. So this was, we came up with this guideline somewhere in early this year, somewhere in February, March. So in March, we started receiving our first patients. And so now we're advanced in to this program with ISN. So what are the preliminary data? Of course, we don't have a full data set that I can share with you yet, but basically for the athlete data cohort from February to August, so the average age of the athletes coming to us is of course fairly young, 18.5 years old. And athletes that, because by our colleagues in National Sports Institute, so they only flagged up those who with cardiovascular symptoms. So what symptoms were the most commonly referred to us for? The primary one was any sort of chest pain or chest discomfort. So these were patients post-COVID, category 1 or 2, coming in complaining of tightness over the chest, chest discomfort, and some of them even chest pain on exertion. And second most common complaint was actually reduced effort tolerance, meaning they felt that they really couldn't push despite following the graduated return to play protocol. They really couldn't, they just felt that there's exercise intolerance. So those were the two most common complaints. So out of the cohort that we had, actually 2 out of that means 12.5% actually were high. And those that were flagged for cardiac MRI, in this case, our data sample was fairly small. But in that small sample, actually 2 of them that we sent for cardiac MRI both came back with findings of myocarditis. So that's fairly sobering for us in the sports medicine world, saying that even those post-category 2, even locally in our data cohort, that they did come back with findings of myocarditis via the cardiac MRI upon following the algorithm. All right, so that's actually the end of the part where I talk about how we clear these patients. So actually the next, in case some of you are wondering, so if in our patient population, for general population, where do we go? So once we've screened them, actually what's important in COVID is graduated return to physical activity, meaning if you're a general population, if you've had COVID, chances are that you can feel the difference post-COVID. So how are you supposed to return yourself? So of course, screening is possible. So you've coming back to this like phased approach to return to exercise. So it's actually the same flow even for our higher level athletes, though the time is a bit different based on this one is for general population, but our athletes, they do a bit expedited, but it's still a stepwise approach to returning to exercise in terms of not overloading it all at once. So it's a gradual increase in both time, intensity, as well as type of activity allowed, meaning initially we don't allow strength training. So this is an example, like the basic guide of exercise rehabilitation, but of course we tailor it, as I said just now, based on each individual and their complaints. And also, of course, the investigation results. So basically, I think, yep, that's actually all that we wanted to share from our side. I think this is actually our first opportunity sharing it, I guess, with all community. And I'm sure there are much more COVID experts out there. We would love to hear from you, from your side, if you have any concerns or any comments regarding this program that we've started. I think that's all from me today. Just ending with a quote: coming together is a beginning, staying together is a process, and working together is success, of course, by Henry Ford. And I'm passing the floor back to my consultant, Prof. Sharif.
Thank you very much for that very interesting and insightful presentation, Dr. Nadirah. And ladies and gentlemen, if you have any question, do type in the Q&A box there. I think at the moment, we have one question from Dr. Yu Kuen Chan. I think the question goes, Dr. Nick, how does one know that the myocarditis is not related to the vaccination they may have received? It cannot be differentiated, can it?
Thank you for the question. In truth, yes, we cannot really pinpoint what is the assault, whether it is COVID itself or from the vaccination, but most of the patients referred to us had a from, especially from those we were talking about that we did pick up myocarditis was among the athlete population. So most of them actually presented with symptoms of and chest tightness, very short duration after their initial COVID illness, meaning most of them were between the range of 2 to 3 weeks post of course, because they are high level athletes, so they were training at a very high level. So they have a graduated return to play. So when they cannot tolerate for any reason, then they get flagged to be screened by us. So the timeline sort of matches more with the post-COVID infection rather than vaccination, but of course, an observation and not a causal relationship. We wouldn't know like this because it's something to be just observed clinically.
Oh, sorry, I was rechecked just now. So perhaps I can also ask one question, Dr. Nadirah. Remember that two athletes with myocarditis. So perhaps you can elaborate what's going to happen to them in terms of their career and so on.
Right. Thank you, Prof. Shari, for the question. So why is it particularly concerning for us when the athletes develop myocarditis is because it depends on the severity of the inflammation on the heart. This is what I understand from discussions with the cardiologist. So if on cardiac MRI, it's just myocarditis, there's no evidence of scarring, then there is a potential that with adequate rest, then they might be able to return to play. Adequate rest here, meaning for an athlete, they have to rest a minimum of 3 months, possibly up to 6 months to see whether the inflammation at the myocardium is reducing. So they get a serial MRI to monitor and see whether the inflammation reduces and so whether they are fit to return to play. This is in the event there's no scarring. So if the initial investigations or the MRI shows scarring on the myocardium, then there is a possibility that even with rest, it will not reverse. So this might be sort of a life-changing moment for these athletes because this might mean that they will not be able to return to play at all. So it's a significant moment for the athletes sort of when you are diagnosed with myocarditis. Yeah, so it's definitely something that we are looking out for. I think there's a question by Dr. Lim CM. Are all the athletes vaccinated? Right? Yeah. Yeah. All our national athletes have completed 2 doses, and most of them have also received the booster doses. Because apparently, if you remember, the booster doses were only rolled out some like mid this year. So some of our patients actually predate that. I told you it started in February. So there are patients who initial part of the program did not yet receive their booster dose, but the later patients, as soon as the booster doses were rolled out, all our athletes also received the booster doses. So that's really, no issues in terms of vaccination of our athletes.
Yes, I think there's one more question there. Perhaps you can read that as well.
Do they get treatment besides rest from the cardiologist for the myocarditis? Yes, I don't know if there are the cardiologists in the audience. That probably be the expert to talk about that, because once we pick up myocarditis, sort of care shifts from us being the primary team to them being the primary team, and we sort of like communicating with them. But from what I do understand is that yes, for the 2 patients that were diagnosed with myocarditis, they do get started on medication as well, and it means that they stop completely from training. Meaning, if you're an athlete that train 7 to 8 hours a day, now you're doing 0, like you're coming down to no training at all. and they get started on medication, sometimes beta blocker, sometimes colchicine, and I think the rest of it, I won't dig a hole for myself and commit to more, but that was what the two patients were started on.
Okay, perhaps are there any other questions in the chat box? Okay, there's one more coming from Dr. Lin again.
Right, I just read it out loud. In other post-viral syndromes, there is an observation of flu-like syndromes that can be provoked by exercise, post-exertional fatigue, I believe it's called. Do we have management flow for post-COVID patients? Right. If I can just reshare my screen and help me answer that question, hold on. So actually, yes, going back to your question, any post-viral illness has the tendency, it's a sort of like post-exertional malaise or post-exertional fatigue is sort of a debated thing. Some camps saying that it's definitely there, and some camps saying that it's being blown out of proportion. But regardless, if you follow the recommended graduated return to play, if I draw you to the phase 1 and phase 2, you should be able to, meaning you should not increase the level or intensity of exercise if you have persistent symptoms, meaning anytime at any phase of, meaning you look at phase 1 is fairly gentle, just activities of daily living. But if you are unable to proceed, meaning you still feel that you have struggling to do activities of daily living, then you should not proceed to phase 2. So that's a way sort of like symptom limited progressing to exercise to prevent that. One of it is to prevent worsening the situation. Yeah. So this GRTP table or recommendation is really coming out also to address that as well, to not overexert beyond the capability of that patient, because recovery might vary from individual to individual. So you sort of stay in that phase until you feel comfortable, meaning no symptoms, you don't feel worsening symptoms, recurring symptoms, then only you are allowed to proceed to the next phase. So that's how we sort of use this table. So yeah, internationally, that's also how the sports medicine community is addressing that problem, to not worsen the symptoms via exercise, at the same time to allow patients to also return to exercise. Yeah.
Okay, thank you so much. I think we are running out of time. If anybody has any other question, you're welcome to type in the chat box, and we're trying to answer it through the email and or not. And thank you very much, Dr. Nadirah, for excellent presentation. And thank you, ladies and gentlemen, for being with us this morning. And to everyone, have a very nice week. Thank you.
Assalamualaikum.